All right, I guess we'll get started. I'm David. I'm one of the Spine Fellows this year. Um, so be talking about the sort of classification systems for adult spinal deformity and kind of how we got to what we have today. In terms of putting everything together, thinking about what makes classifications good, what measurements we use, sort of the early classifications, history, and then sort of what we use in practice today. In terms of classification systems, we use it a lot throughout orthopedics. Most of them aim to either describe the injury pattern or give some prognosis on terms of how well you expect you to recover. Also, they can be useful for indicating different treatment options. How good a classification system is also depends on how reliable it is between intra and inter-observer reliability. So the same person classifying the same injury the same way between observations, and also different observers also classifying the same way. This is typically measured by the kappa statistic, which looks at the difference in agreements percentage relative to the total number of observations. And just for reference, we're looking at sort of a kappa score above 0.6, 0.7 to be kind of acceptable. Some measurements that are commonly used, traditionally the Cobb angle is kind of the easiest way to describe a curve. The apex of the curve is typically where the Cobb angle is the greatest between segments. The peak vertebra in the curve. And then in terms of your pelvic sagittal measurements, you have your sacral slope, your PI, pelvic tilt compared to your lumbar lordosis. And then your SVA kind of tells you, if you draw a C7 line down, where do you center relative to your sacrum? And that kind of gives you an overall global sense of their alignment sagittally. So for some historical context, the Schultes classification was first described in 1905. He's a guy out of Switzerland. And basically all he did was look at the anatomy of these curves that presented to his clinic and categorize them by anatomy. So either lumbar, thoracolumbar, combined thoracolumbar, thoracic, or cervical thoracic, as well as this double primary combined group. In 1950, Dr. Ponsetti, who is out of Iowa, he was a pediatrician, I think. He published a similar report on the percentage statistics of each curve type. So purely descriptive, kind of telling what's the average curve when they presented. All of them were treated non-operatively back then, and then where the final curve ended. So just some baseline statistics. You can see the distribution of where you see the curves. So, cervical thoracic and upper lumbar were kind of less common versus thoracic and lumbar curves. In total, he had 394 cases that he treated non-operatively. 1973, there's Dr. Goldstein. He published a classification based off the etiology of the curves. This was still mostly looking at pediatric cases. Idiopathic was kind of the most common, but unidentifiable underlying cause, thought to be some kind of genetic condition that progresses variably. He subclassified this by age of presentation. So when did you first see the curve? Infantile under 4, juvenile 4 through 9, adolescent between 10 to skeletal maturity, recognizing that they kind of behave differently and different prognoses. Congenital malformations were typically from abnormal bone development or formation of hemivertebra or missing vertebra, possibly also including spinal cord abnormalities with tethering or syrinxes, myelodysplasia as well, and then or even like a bifida myelomeningocele. Neuromuscular cases from neuropathic or myopathic etiologies. Neurofibromatosis was also commonly seen, as well as mesenchymal disorders, which include Marfan's or arthrogryposis, and then kind of a subset of that was acquired disorders like rheumatoid arthritis. And then finally, there's post-traumatic scoliosis. So you get a fracture or some, they also include iatrogenic causes. So getting a flat back after surgery, or some kind of coronal curvature after surgery, or radiation causing a curvature over time. So this is a different way of thinking about scoliosis and what is the etiology, but didn't necessarily help guide indications or treatment or describe any prognoses. Dr. King was out of Minnesota with Dr. Bradford over there. This was published in 1983, the first classification to help guide treatment in identifying sort of how to select your fusion upper and lower instrument and vertebra, trying to describe the different types and curve patterns that might be amenable to it. So they, again, mostly looking at pediatric or adolescent idiopathic scoliosis. So they retrospectively reviewed all their patients at Gillette Children's Hospital over a 30-year period for patients who had undergone surgery for idiopathic thoracic or combined thoracolumbar scoliosis. And this was one of the first papers to define the stable vertebra, which is the most closely bisected, the last stable vertebra perpendicular to the sacrum and the iliac crests. So that helped them sort of point out a guideline on terms of how long the construct needs to be. And they also described bending films, which was a proxy for flexibility, and specifically their type 2 curve. They found a high rate of success for selective fusion, meaning they would only address if the patient was thought to be flexible, they would address the main curve and allow for compensation of the secondary curve. And this was nice because it helped sort of set the framework on how to assess what to do surgically and would be adopted into thinking and management of adult idiopathic scoliosis, adult scoliosis as well, adult deformity. In 2001, Lenke classified adolescent idiopathic scoliosis further based on the Cobb measurements to define major curves. Structural curves are typically if the side bending films remain greater than 25 degrees in the thoracic spine, or if kyphosis was greater than 20 degrees. The definition of these curves in terms of where thoracic or thoracolumbar are typically thoracic was the apex of the curve was somewhere between T2 and the T11-12 disc space. Thoracolumbar curve had the apex of the curve between T12 and L1, and lumbar was between the L1-2 disc space and to L4. So that's kind of how they define these different categories. They also introduced additional modifiers that are still very helpful to look at the central sacral vertical line and the stable vertebra that was sort of adapting off the prior chemo classification. And they would make ABC, whether or not the medial border of the lumbar concave pedicle and lateral margin of the apical vertebral body was if the CSVL was between those. And then B is if it's the CSVL was medial to lateral aspects of the lumbar apical vertebral body, and then or sorry, A was in the center, B was lateral to, and then C was medial to the lateral aspect of the lumbar apical vertebral body. So they also added the thoracic sagittal profile and graded it based off of between T5 and T12. Is it hypo kyphotic, hyper kyphotic, or normal? This classification, it was aiming to help guide treatments, but for some time it was never shown to correlate with pain or dysfunction. It did have excellent inner observer reliability scores, a cap value of 0.92. And then for the sub modifiers, they range from 0.89 to 0.97 amongst 7 reviewers. One criticism is that this classification ends up with 42 different types of curves when you consider all the modifiers. And then 2005, this was one of the first studies to, skip that one. In 2005, this study by Max Aby proposed a classification for adult deformity with type 1 being kind of a de novo, mostly on limited disc degeneration. So kind of not showing any signs of disc degeneration would be considered de novo. Or he also called it a discogenic curve, meaning a lot of the deformity was from the disc. He says that usually the apex for this type was between 3-4, L3-4, and L2-3, and it was associated with the loss of lordosis. It was thought that the sagittal malalignment in this type of curve was proposed in this paper that this could be the primary pain generator in back pain. Type 2 curves were these idiopathic scolioses that have been present since adolescence and childhood that then progressed over time. That these were also in later stages starting to show sagittal malalignment as well, with kind of flattening of the curvature. And type 3 was described as secondary degenerative scoliosis, meaning whether it be idiopathic congenital neuromuscular conditions from a lumbosacral or a lumbosacral anomaly, that there was resulting degenerative changes that worsened this curvature. He also described a 3B, which is kind of from poor bone quality, a metabolic classification that accounted for osteoporosis leading to curvature. It didn't really significantly guide treatment, but one thing that this classification did was point out varying degrees of where the curvature might be coming from, the contribution of degeneration, and also how important the sagittal alignment seems to be in relation to their symptoms. Building upon the the previous Kingmo and Lenke AIS classifications, this 2006 paper was kind of one of the first to adapt it for the adult, and also focused more so on degenerative aspects, including the stenosis, spondylolisthesis, as well as rotational subluxation. They again went with the 6 major types of coronal curves. And this time they also point out primary thoracic, as well as upper thoracic, proximal thoracic, main thoracic as separate categories. The primary thoracic, the major curve for it to be primary had to have a 40 degrees curve, and the C7 plumb line had to lie lateral to the apex of the vertebral body for that to be the primary curve. And they used 40 degrees here because that was kind of agreed upon that would be a reasonable cutoff for surgical intervention. The upper thoracic curves was defined as the patients who had the first thoracic rib or clavicular tilt having to be more than 5 degrees. So having some shoulder type asymmetry there. That would classify them as upper thoracic. And then thoracolumbar curves, they defined as having more than 30 degrees magnitude, as well as the CSVL passing lateral to the apex vertebral body. They also added this lumbar degenerative modifier, trying to account for disc degeneration and instability. Overall, with the reliability, they had 14 surgeons evaluate 25 cases. The overall interim reserve reliability was 0.64. For the additional modifiers, between 0.65 and 0.92, which demonstrated it was pretty reproducible. I think primarily this first adult deformity classification was to try to help homogenize patient populations for research studies so that you could kind of agree what subset that you're studying. But also they were trying to point out considerations that you could take into account when making a decision based off of managing the surgically. But that was kind of one of the first ones. Then in 2005, around the same time, Rusoli had this description where he was really focused on the sagittal alignment more so than the coronal classifications, the classifications that primarily focused a majority of their cases based off of Cobb angles in the coronal plane. So he looked at 160 volunteers with no history of scoliosis or back pain and obtained full-length standing films, and then basically clustered patients into sort of these four types of either low or high pelvic incidence, or initially it was described as sacral slope. So basically for type 1 and 2, the sacral slope was less than 45, type 3 and 4, it was over 35. And he was looking specifically at where the lordosis apex was to try to help differentiate these. So for example, type 1 and 2, falling between within L5 of your apex versus L4 being your apex lordosis sort of was one differentiator there. So this was kind of the first to look at pelvic parameters and describe why it's relevant in terms of figuring out what normal is for people. Pelvic tilts then started to gain more traction as an important parameter in 2009. This paper was published from the Lafage. It was 125 adult spinal deformity patients. All of them had radiographs measured, and they tried to correlate this with ODI, SF12, SRS, and see what measurements seemed to correlate well. Nothing in the coronal plane seemed to correlate necessarily with outcome measurements. However, the SVA and pelvic measurements did seem to correlate, with the pelvic tilt having a pretty high correlation with both quality of life measures as well as predicting sagittal vertical alignment. So they thought that from this, they surmised that high pelvic tilt is probably your compensatory mechanism when you're starting to lose lordosis to help keep your balance in harmony. So from these groups looking at their pelvic tilt, they found that as you had higher pelvic tilts, the outcome, the disability scoring was higher, meaning worse, and the physical component scoring on SF12 was also worse. The classification of each of these categories of low pelvic tilts and relative to the low at SVA, as well as combinations of those, helped also stratify these patients with their degree of sagittal imbalance here. So this was one of the first studies to demonstrate that the quality of life and the outcome measures does seem to correlate somewhat with what's going on radiographically. So that kind of starts the conversation of, well, what are we trying to correct with surgery? Is other goals that we should be trying to target? Then in 2012, this was an updated version of the previous adult deformity classification that was kind of called the SRS Schwab. Again, based off of the coronal curves, with the major curves being 30 degrees, and structural curve also had to be over 30 degrees for it to be considered structural. They again looked at these additional modifiers, this time focusing a lot more on sagittal characteristics. And, maybe this was oversimplified a little bit, but how much pelvic tilt they, based off of these previous studies, 20 degrees was thought to be normal. And then having the SVA below 4, as well as PA minus lumbar lordosis mismatch, which at the time kind of changed the way we sort of approached the targeting goals and set a framework for. So here's on the right an example of how they would classify based off of the apex, the magnitude of the curvature, and then the sagittal modifiers. For this classification, they had 9 readers, grade 21 cases twice, 1 week apart for 2 readings for each reader. And they got a kappa coefficient of 0.81 overall, with the modifiers scoring between 0.75 to 0.97 for these 3 side modifiers. Building upon the Rusoli, then in 2018, one thing he noticed from looking at patients, sort of an outlier, it seems like, was in 296 patients. So he again kind of measured asymptomatic patients, looking at all these pelvic parameters and global alignment. And he thought that there was a subset of a type 3 curve with a very low PI, despite having a high sacral slope. So for these patients, he sort of described them as an anteverted pelvis with a sacral slope between 35 and 44, with a low PI less than 50. So he noticed that these patients with anteverted pelvises usually had 0 pelvic tilt, but had severe low back pain, and were kind of hypercompensating through the lordosis. So when he treated these with fusion, it ended up decreasing the overall lumbar lordosis, which happened to increase pelvic retroversion and tilt. And he found with this type of patient, the SVI, the C7 plumb line would go from starting off anteriorly to being aligned in the mid sacrum. So this was an example, I think, of how you can't apply the same principles across all patients. And this was specifically a subset that sort of behaves differently in terms of their sagittal alignment. Also, one interesting finding in a subset here, looking at females, they generally had lower pelvic tilt in the cohort. So he thought that restoring lumbar lordosis may be even more important for females. Otherwise, major limitations that people discuss about this classification: small sample size, mostly young, healthy adults, all Caucasian subjects, so not globally necessarily applicable. Finally, going back to coronal classifications, Bao published this paper in 2016, separating 3 types of coronal curves based on the balance of the center sacrovertebral line with the vertical line with the C7 plumb line, looking at the difference between these 2 vertical landmarks. A meant that they're within 3 centimeters, and then if they're greater than 3 centimeters, type B had to do with if the lines were displaced, the C7 plumb line was displaced, and the concavity of the deformity versus the convexity of the deformity. And that's a little bit helpful. This classification tends to be helpful with treatment because you're trying to see if you were to correct the major curve at the apex, what would that do to the coronal balance of the head sitting over the pelvis? So he noted that when you're correcting a type C, an osteotomy at the apex may actually worsen the coronal balance since you're sort of tilting off to the side and make the coronal balance even worse. So it emphasized that you need some kind of correction of the fractional curve prior at the base from 4 to 1 before adjusting the primary curve. This OBEAD classification is close to 730, so I'll speed up a little. Also was trying to further describe coronal malalignment with a similar classification. And really they're trying to identify these subtypes based on flexibility of the curve, of who might need a major osteotomy to help correct the coronal deformity or not. Again, focusing on flexibility, typically this is sort of showing that the malunions and patients who are fused often will need an osteotomy to correct the curvature. And then lastly, I think this study in 2022 is sort of the bread and butter of how we think about deformity sagittally now. The T4L1 axis kind of shifts to more of a continuous variable rather than classifying into 4 subgroups to try to understand the axis of where each of the vertebra sits. And basically they looked at a large amount of asymptomatic patients and found that the 2 measurements, the L1 and T4 pelvic angle, tend to be highly correlated in asymptomatic patients. And really, for me, I think the takeaway is you should be looking at earliest possible films of sagittal balance. If they have a film before they had degeneration, that helps guide what your correction should be like now that we have x-rays from early from 10 20 years ago. And the nice thing about this classification is it sort of tries to show you where the compensation is happening, where you lose your curvature from degeneration, and where ideally your correction should be. But I think the big takeaway is at the L4-S1 segment across most types, you're looking at somewhere between 35 to 40 degrees of lordosis. And then fine tuning the upper lordosis or lower thoracic compensation really has to do with where the L1 and T4 PA tend to line up. So I think this is, and if you want to generalize that, it's basically low versus high PI or sacral slope have different distribution of curves. You can see a good example of that on the right, that these are very different looking spines sagittally, and trying to correct into one versus the other may not be right if your pelvic parameters aren't that specific, look like that initially. So to conclude, a lot of these classifications have evolved over time, and they're all coming together now, looking at both coronally and sagittally and trying to incorporate that into your game time decisions. But they're helpful in identifying the severity of the pathology, trying to understand the prognosis of whether the curve will progress. And ideally, these classifications get less complicated, not more complicated, and they're easier to apply and are easy to remember. But as we can see, adult spinal deformity still very much in the being figured out as we go, very complex with a lot of contributing factors. These radiographic parameters only being one aspect of the overall picture. But I think these more recent papers definitely seem to be applicable and help guide. Seems like it's more and more so being a algorithm that you're following in the OR rather than sort of, you know, uh, having a preference in how you like the curve to look or how you like the rods to sit. So undoubtedly, this classification systems will continue to evolve over time. Thanks. If anyone has any comments on any of the prior historical classifications or their implications, I'm sure some of you have been doing this a long time and have a lot more depth and knowledge on this topic.
I haven't been doing it that long, or long at all. It's just interesting to see how things change, over the last 30, 40 years, 20 years, 10 years. And now with like these new things, and you go to these meetings and there's always something new and you never really know kind of what's going to stick. Um, and so, I feel like what we're learning now 10 years from now might be totally different. And that's just kind of like the exciting part, because you can help be a part of that kind of change for it. I think that was a good summary of everything.
Yeah, I think of it a little bit like in the context of music. People said you're going to lose human touch if you digitalize everything, and it used to be this complex, like theory based, the human brain putting the instruments together. But now more so, it's becoming more digitalized and produced, and looking at hard numbers and trying to objectively quantify what music is. And it has a little bit of that same thing. There's still a human feel of how the music comes together, but it seems like it's transforming more so from like the organic type of like human art versus having more science behind it with a human operator sort of orchestrating it.
You got a lot of companies now, Medtronic with like the Metacrea, Nuvasive, and Globus, and I just saw on LinkedIn this weekend another company pop up for creating rods and finding the perfect alignment. So it is evolving, and it's using the technology to try to figure it out. But how much human touch do we need?
Great. Thanks for tuning in.